Hello, my name is Joyce Kimani, registered nurse, director of the Chronic Disease Clinic, and currently overseeing the Telehealth program. How are you?
Good, how are you doing? Hi, my name is George. I am the Senior Vice President and Chief Financial Officer at Azusa Regional Medical Center. I'm part of the executive team in charge of funding new programs, and I'm excited to hear about your proposed telehealth program.
Our hospital service area includes a large rural population with many of our patients currently residing on Native American tribal lands located 3 hours away from the hospital. A high percent of these patients who get hospitalized from the tribal lands carry a diagnosis of type 2 diabetes with multiple comorbidities. Diabetes is one of the biggest health problems for the American and Alaskan Indians. The CDC estimates that American Indians and Alaska Natives have the highest prevalence of diagnosed diabetes for both men and women in the U.S. The diabetes epidemic in the American Indian and Native communities is associated with a number of factors that include predisposing genetic risks, lifestyle behaviors, geographic factors, and low socioeconomic status. A significant proportion of the health budget is consumed by diabetes, especially in the management of diabetes-related complications. In addition, the total budget in terms of health resources, reduction in quality of life, and personal suffering is unknown. According to statistics collected by the hospital, the admission rate for these patients is high, with many of them coming back to the hospital less than 30 days after discharge. Due to their geographical location, many of these patients find it impossible to travel to the city for medical follow-up. Another factor that affects the readmission rate is the high volume of patients, making it hard for the available diabetes educators to keep up with referrals, especially since they typically have only 1 hour to provide education for these patients before they are discharged home. Unfortunately, it is unrealistic for our home health nurses to make visits to the reservation. There is a community clinic located on the reservation that is open to tribal members. It is staffed with an LPN and one administrative personnel, but it is currently not able to sufficiently care for the diabetic population. In light of the above situation, tribal leaders are interested in partnering with the hospital to address the healthcare needs of the population suffering from diabetes. After much brainstorming, the hospital leadership is interested in establishing a hospital-based telehealth program to manage the healthcare needs of the type 2 diabetes population. The program will be an adjunct to our already existing and profitable home health program. A SWOT analysis has already been conducted. The strengths of the hospital include an already existing profitable home health program, cooperation from the tribal leaders, and convenience of accessible healthcare to the patients who would otherwise have to travel long distances for medical follow-up. Weaknesses include the cost of setting up the program, which includes money for telehealth equipment, marketing, and program setup. Other weaknesses include lack of the hospital's presence in the Native American community and the need to recruit and train healthcare personnel. The opportunities we have include reduced rate of readmissions. Since patients will have access to healthcare personnel through the telehealth program, they will be able to receive prompt care instead of waiting until it's too late and ending up being readmitted to the hospital. This will in turn reduce the financial burden to the hospital and provide improved care of life for the Native American population. The hospital will also establish a partnership with the community through collaboration with the Native American community. Threats include lack of cultural competency from hospital staff and the fact that some of the patients may be technologically challenged and thus might hesitate using the telehealth services. Marketing will be an important part of the program. We need to raise awareness, obtain revenue, and convince patients to use this service. We will need to market to the Native American community, who will be the main consumers of the service, and without their buy-in, the project will not succeed. The tribal leaders should be included in this group since they have influence in the community and they will be able to mobilize the Native American population to utilize this service. Family members should also be included. Benefits of the telehealth program will be discussed, including reduced cost of travel and improved quality of life for the patients as well as the community at large. A brochure has already been designed for marketing to these stakeholders. It includes the hospital's mission, vision, and values. It shows the seriousness of diabetes, the need for consistent healthcare, and what the hospital is doing to help with the management of this community. Here's the brochure.
Do you have a proposed budget?
To help with planning for the first year, the hospital has agreed to disburse $200,000 for the first year of operation. Other sources of revenue include Medicare and medical and self-pay patients. Medicare will be billed at about $70 using code G0425. Medicaid will be billed at around $80 using code 99244. And according to market research, we will be billing $75 for the self-pay patients. The total revenue for this will be $80,000. Combined with the 200, we will have a total of $280,000 for the first year of operation. The most expensive expenditure will be the cost of labor. We will be hiring a nurse practitioner, registered nurse, and medical assistant. Their combined wages, including benefits and social security and Medicare contributions, will be a total of $225,000. Capital expenses incurred during the first year will go towards the purchase of 2 vital signs machines and 2 glucometers in July, with an addition of the same in February due to an anticipated increase in patients. Instead of hiring a legal consultant and an IT specialist, the services of a company that offers a web-based platform will be enlisted. These types of companies have experience with telehealth and provide services that are compliant with HIPAA requirements. They offer virtual meetings and waiting rooms and provide technical support. We have identified SJC as a good match. In addition to the aforementioned, SJC Telehealth offers video conferencing software, month-to-month services, setup help, training, support for all endpoints inside and outside of the organization for $300 per month for unlimited session. Marketing will be another expenditure. Brochures and flyers will be printed and distributed. The nurse practitioner will be in charge of community outreach events to be held every 3 months at the clinic at the reserve. Another cost will be the overhead and office supplies. The hospital will not be paying for rent, but we will assume the utility charges. This will include electricity, telephone, water, and internet services. The total expenditure is estimated at $256,000. This will mean we'll have a net profit of $23,000 for the first year of service.
And what's your proposed timeline to go live?
The proposed timeline to go live date will be 7 months. In November and December, we're going to have a stakeholders meeting. We will make sure that there is a buy-in from everybody. During this time, we will ensure that goals of the program align with the organization's mission, and we will also formulate a plan of action and allocation of monies. In January and February, we will start the credentialing process and acquire any necessary certifications required by Medicare, medical, and any other payees. Legal issues will be addressed at this time. We will start marketing in March. We will assign 1 month, and focus should be on reproducing flyers and brochures and distributing them to the doctor's office, the rural clinics, and the main hospital. Short in-services and continuous reminders to the doctors, nurses, clinic LPN, and other personnel should be done at this time. We will be emphasizing the need to make sure all eligible patients get the flyers and explanation of the new telehealth care program. This will be done continuously until the go-live date. In April, we will contact the online platform provider, including ordering and installation, which will take about 1 month. Vital signs machines and glucometers will be purchased at this time. In May, we will assign 2 weeks for testing all equipment, including the telehealth care online platform, conducting practice sessions for the clinic, and fixing any issues that may arise. Training will begin in June. We will allocate 2 weeks, and if needed, we will allocate a 3rd week.
And so how are you going to evaluate the program success?
It is indeed important to have a way of knowing whether the telehealth program is meeting its objectives and that it is also a financially sound investment. Patient quality outcomes that can be used include patient satisfaction surveys and reduced rate of patient readmissions. Patient satisfaction surveys can help identify ways of improving practice. Ultimately, that translates into better care and happier patients. This can be done through phone surveys, written surveys, focus groups, or personal interviews. Other patient quality outcome is reduced rate of hospital admission and can be measured by comparing the number of readmissions at 6 months and 1 year after implementation and readmission rates at the same interval from previous years. According to an article by Nerzin and Neal, unexpected readmissions in particular for the same clinical condition are almost always interpretable as a measure of poor quality. Financial outcomes can be measured using accounting measures like net gain or losses. These measures reflect the most aggregated analysis of the balance between revenues and expenses. This can be done quarterly and can show that the program is operating at a loss or profit. Another financial outcome measure is reduced hospital rates, which translates into money saving. Under the proposal from Centers for Medicare and Medical, hospitals are financially penalized when patients are readmitted within 30 days of discharge. This can be calculated by collecting data on readmission rates at 6 months and 1 year and comparing with previous years and calculating how much money has been saved from lack of financial penalties from payers. To recap, this program will benefit the hospital by reducing readmission rates from diabetes, which cost the hospital money from penalties from payers. Will also reduce healthcare and financial burden from patients who can benefit from outpatient services. By doing all this, we will establish a partnership and presence in the Native American community. The advantage for the patients will include accessible medical care, improved quality of life, and saving of time and money for travel from the city for medical follow-up.